All right, so we are back with another PCBH Corner. And
it's been a little while.
It has been.
It's been a little while.
Yeah, well, at least between you and I, because I think our last PCBH Corners had guests.
Yeah, absolutely right, and they were great. That's actually a really good point. Yeah, so it's nice that you and I are back. Yeah.
So, super fun topic, and this is a topic that we've been wanting to do for a while, but it's basically addressing, not even exactly sure how to say it, making a new benchmark for what makes the therapeutic encounter, and as a clinician, a new benchmark for what makes it successful. And I'm going to get into this by asking Dave some questions to have him explain, and then we're going to just, see what happens.
Yeah.
All right.
So I think
I was going to ask you.
Well, here's the thing, though. I think I'm excited right now to even have, and my mind goes to. I think it'd be good to even lay the context of what my recent kind of thought is like. Man, we need to do a video about this. So we were doing a didactic, one of our internship didactics, and Jeff Ryder had come, and we were talking about just what are some of the roadblocks still that people have with PCBH? What are some of the barriers? What are some of the things that people just continue to struggle with? And one of the interns said something that was really interesting. They said, I'm struggling with the fact that I just don't get the warm and fuzzies about the visits that I have with patients a lot of times. And then he went on to explain that it's largely due because, one, time. He doesn't have as much time as he used to do with when he was in a traditional setting. And the second thing was necessarily these like constant follow-ups. So almost like another definition of time. So one was like the length of the visit, and then time as far as just like multiple follow-ups.
Oh, the lack thereof in PCBH.
Exactly,
okay,
the lack thereof. Both of those domains, right? Both of those things. One of those, lack thereof of the actual minutes spent with the patient, and then lack thereof is like these constant follow-ups.
So one of the big barriers to this person who was talking about the stones in their shoes with regards to the PCBH model was that he did not feel that he didn't feel good about his work, largely because he wasn't getting the same quantity of time and he wasn't getting the same frequency of time.
Exactly.
Okay, got it.
So then my mind, when I was sitting in that didactic, I was thinking, I was like a good functional contextualist, what has produced that psychological event of defining good care, quality of care, the warm and fuzzies about care based on time? Because there's nothing inherently true about that. It's not like the universe started and they said this is what is the definition of good therapy or behavioral health intervention was duration of the visit and then frequency, right? It was something that we learned. It was something that we were taught. So this is where my mind was like, man, what if we were taught that access gave us the warm and fuzzies? What if that was something that our context created as a relational frame? That the more people we saw, those moments that Rosenbaum always talks about, what if that was the definition of good care, the warm and fuzzies?
I think that's how, at this point, as a BHC, that is how I feel. I mean, absolutely what happens with the patient and doing good clinical work and patients saying that this was helpful, super, super high importance. I don't necessarily tie that to time anymore because I've had, really great 13-minute visits and really poignant 24-minute visits. So I think my brain has now broken that assumption, or not assumption, kind of association.
Yeah.
And when I put like you're saying, so defining the warm and fuzzies is feeling good about what you did. Like when I finish a clinic or a day, and I'm going to hang my hat on that day, what I hang my hat on is how many different patients I was able to work with.
The number of moments that you had with somebody, and different people.
Yeah. And the warm handoff piece, because then it makes me feel good about being able to support the medical team. So that access piece goes both ways. The access for the medical team to get me, and then also the access for the patient. And I do think, now I'm jumping the gun here, I think one of the things that really drove that point home to break that initial association in my head about, length of time gives me the warm and fuzzies about my care, is shadowing the medical residents on their patient-centered communication skills. So when I'm in the room, I'm shadowing them, and then it turns out that they want to get a BHC involved. how urgent it feels and like how much it'd be helpful to get a BHC. And when we're able to come out of the room and we have a BHC waiting for us, now, because in that role, I'm not taking handoffs. In that role, I'm doing the patient-centered communication. And when we're able to say, you come and you take the handoff, and I know, man, Dr. Bauman is taking this. I see the quality and the importance of you being able to do that, of answering that handoff. Because in that moment, I'm like in the PCP's lens.
The thing that I love that you said, and I think I thought of this, but you did such a good way of explaining that I don't think I ever was able to actually articulate what I was thinking or feeling. It's two things about access. It's about access as far as unique people, how many unique individuals you're seeing. And then as you said, like in the moment access. And that's what primary care is really about. And what's interesting as well, when you bring up the residents, like when we talk to the residents, for sure, residents, I think, and all physicians would be like, I wish I had more time with patients. I think a lot of people feel that way. And so it's not the same though. Like they're not saying their care is bad. They're just like maybe like a preference. Like, yeah, I wouldn't mind a little bit more time with people.
Oh, interesting.
The reinforcement though for them is about seeing unique people and in the moment of care when they need that someone can get in that day. It just is a really, I don't know why that struck me, how you were explaining that. I think it was just really well said. It's that it's both unique and in the moment access to care.
And maybe this is one of those things that's like, it's self-propelling, that once you're in this context, once you're like, because if you're new, because that's kind of where this came out of, because those folks are new.
Yeah.
And for those of us who've been doing it for several years, there's so many things that reinforce this idea. So when you have 2, 3, 4, 5 years worth of patient interactions where you're able to see them that day, and they're like, oh, I absolutely wasn't going to stay. I really didn't want to do this today. And then you have the visit, and then they're like, thank you so much. Like, this was so helpful. You have dozens upon dozens of those.
It's going to build a relational frame.
Yeah, it builds a relational frame in my head of like, I can't miss this warm handoff because I'm going to be missing an opportunity for somebody who literally was going to close the door on it, who's opening the door. I'm going to miss an opportunity to help support a PCP who's like really trying to get through their day. Whereas if you're new to this, you haven't had dozens and dozens upon. You've had the opposite.
I was going to say, think about the training that they have had. Like, what did we have training like within our traditional setting? Like, very rarely did we get, you would have someone like in crisis and different things that might be coming in that moment. Not in the same vein though, like that this just happens regularly and often, and not about people again in like a crisis. This is just like everyday care. That something. Very rarely did we get that in a traditional setting. So that almost, maybe that's something we almost should say as well with professors or people that are in grad schools and they're talking about this, being curious about what are you subtly reinforcing are the good and fuzzies, the warm and fuzzies about care with it. Because when we start to break this down, it really is, psychology goes to the one end of the spectrum of this is warm and fuzzies is about time, frequency of coming back. That's what gets reinforced.
Yeah, I mean, I remember very specifically, and this isn't like a knock on anything. It was a contextual piece. They're saying that one of the best ways to communicate respect to your patients is starting the visit on time and ending the visit on time, and that was a really also good display of boundaries and professionalism. So it was respect, boundaries, and professionalism. I know we've talked about that in other PCBH corners. I can't remember which ones at this point. So it was like it was a medium. It was a tool to be able to achieve that. And so I guess as we're just having this conversation, I just have so much empathy for those folks who are new. And I know I'm a big perpetuator of this, where we go to a training and people bring up like, well, I don't have enough time. And I'm like, time? Why do you need it about time? Right. But now that we've broken it down, it's like, they don't have the frame of reference or the point of reference, all the stuff that we just talked about. So we got to be patient.
That was the profound moment that I had in that training.
Oh, really?
100%. I was like, oh my gosh. And it was almost similar to, I remember we had someone come visit us, this was years ago, and they said to us, like, you need to stop saying about look at all the people that you're serving, look at all your people you're serving, because in their mind, the only thing they heard was just like bad care, right? That you're just giving bad care.
Just quick, fast.
So I my mind's gonna be
drive-through care.
We should have maybe picked this up a long time ago, and maybe we were, but it was just that moment with Jeff and the trainee that like came to this like really this tipping point of being like, oh, it doesn't make sense in a lot of ways for people to understand that idea because they never had that relational frame that was a good thing. You could get the warm and fuzzies about that. And so I think that's where it's like we need to start shifting these conversations.
How do we do that? I know you mentioned a little bit about grad school professors really kind of thinking critically about what messaging they're giving about what is good care. What advice would you have to supervisors, maybe who are newer to PCBH, directors in this role? What do you think?
And the one thing I want to go back to professors and grads, even if they're not working in primary care, I think it's important to highlight what is subtly just being reinforced. Like, this is not the only thing, right? Like, this is not the only way of doing this care. And there's a lot of other things out there that we should be worried about.
That we should be looking at for what's good care.
Yeah. I actually wrote that down. It's like, what would I want for like new BHCs? And I think one of the things I've always appreciated about you and how you approach sometimes conversations or preparing for meetings or preparing for trainings is, and I don't know where it comes from, I don't know what book it comes from, but doing the accusation audit, what is that? What is that from?
Accusation audit.
Yeah, what is that from?
That's the negotiation.
Oh, don't split the difference.
Yeah, never split the difference.
Yeah. I think that is something that maybe we should do a little bit more overtly at the beginning, maybe of like orientation and onboarding, telling people it's like, you probably won't feel the reinforcement that you're used to feeling. Give it time through experiences. And then also very much try to be as aware and as possible as what your mind is saying right now. And I think you used the right word. I know you were saying like assumptions, and so it's an assumption about like, what does this person need? Why do I feel like this person needs that? And
it's like both an assumption and an association.
Correct. And the thing that probably would come up is like, oh, you know what? It's just based on these previous experiences. I'm not saying that they're wrong. It's just they might not have told the full truth about what was going on there.
And for the audience, the accusation audit is basically when you're negotiating or, getting into an argument about what's going on, you basically bring to the forefront the main things that they might accuse you of. So it'd be like, so in the PCBH model, like, yes, you are absolutely right that it's going to feel fast-paced. You're absolutely right that your brain is going to worry about if it's fast care, then it's not good care, and all those associations. And so you basically say up front, instead of trying to hide, be like, oh, PCBH is so good.
Just believe this.
Just believe this.
Yeah.
Look at all the positives. Look how many people we've
Look at all the research that shows about it.
Yeah. Bring it to the forefront and say like, it's going to feel uncomfortable. Or it might really be... addressing some of those assumptions or challenging those some assumptions that are very tightly held beliefs about like what is good. So if in your mind 50 minutes is both a tool to honor, respect, and provide good care, and now all of a sudden you're doing it in 30 minutes, then what happened to the other 20 minutes? It's like, well, then clearly it's less than. So just kind of bringing that to the forefront and calling it out.
As always, and this is why I love shooting these corners, and because like every single time I hear you talk, like my mind just goes so many different ways and like explodes with ideas and revelations. And I think this is another one. It's like, oftentimes when we talk about PCBH, it's so ironic how we do it because we do it the same way we tell people not to do it with patients. That we talk about research. We talk about like, hey, you're missing all these different, but we don't get to the heart of what it is. It's like, what's the heart of why people like lean toward this or lean out of this? I would imagine probably, my mind predicts a lot of the reasons why people lean out of this is that it just doesn't feel right. There isn't warm and fuzzies about it.
Yeah.
And I think if we were more honest about that, as we're saying, like calling that out from the beginning, like, you probably won't feel that way, and that's okay. This is just a different type of reinforcement, and we'll get there as far as more experiences and things coming up. It is going to be different.
When do you think that for you, because, I mean, back when we were starting all this stuff, we weren't having these type of conversations. Who even knew what we were associating with success? And at what point was it like internalized? But can you think back to when it became really apparent to you and you started feeling good about your work when you were able to connect with people in moments, you were able to have access versus it just being like, okay, I did 50 minutes and I stayed on time and I honored that.
I think it was levels. I mean, the one thing that's kind of hilarious right now thinking about this is that, we're coming up our, is it the 9th year at CHCW?
We will have finished 9 years.
We would have finished 9 years, yeah. So we're about to start our 10th year. And now we're just having this conversation, So I mean, that's the thing. Like, as far as like the feel of it,
Right.
I think there was definitely levels to it. I think conceptually, I think when we were getting taught it in grad school and doing some of the work that we were doing, we were understanding. And still back in the day, though, it was still about just mild to moderate problems. It wasn't. I never felt good about someone coming in maybe with a lot of ACEs and a lot of trauma and doing this kind of care. Like, that didn't feel good.
Right. In the very beginning, yeah, it's true.
So I think at the beginning there was some recognition about like unique people and trying to get it out, population-based health and stuff. And it probably wasn't actually until coming to CHCW with Kirk. Where's your mind go?
As you were saying that, I was like, I think what changed everything was Kirk because of, which is for some of our other PCBH corners, the Access V one, being able to recognize that you can help people with very intense difficulties right away by identifying a few core principles, which again is talked about in Access V's PCBH Corner. And so when I had that knowledge base and that skill set, all of a sudden I was able to look at the visits differently. And I felt like I could actually help anybody in any period of time. Maybe the competence, and that's another thing that's difficult for new folks, is the competence and the skill set is also going to be lower. So it's just like, it's one of those things. It's like, how do you get competence? You have to believe this, but how you believe this is...
Which goes back to, I think, your brilliant way of doing onboarding. And, this is something hopefully we'll be able to talk about at the CFHA ELO with things with PCBH about onboarding processes. Is that it really does take someone at least a year to not only to be able to hit like the expectations, to really start to uptake what we're trying to sell. And I think that's another thing. If I was going to talk to directors or supervisors and stuff, it's like, give a lot of grace and compassion. What people might be fighting back with isn't like someone trying to be defiant or something. I think back to some of our consulting now. Man, I should have went to the heart. I should have moved towards the heart rather than trying to give facts and all these different things. I think that's the thing of like, give people grace because they're responding to a frame that has been very, very strong.
And we have to build up a new one.
Let me ask you this. Say we were going to do an accusation audit based on this PCBH corner. What would it be? What would it be because in my mind, the first one that my mind goes to is that people are going to say, oh, you don't care about like time. Like, you don't care about, and I think that's the thing, and again, this is where it's not an either or.
Right.
It's an and. Rather than, though, allowing a set ahead amount of time, what would the word be for that? Set ahead?
Predetermined?
Thank you. Jeez, set ahead. I'm just making up sayings.
I knew what you meant. A predetermined amount of time.
A predetermined amount of time before going into a room to be the thing that qualifies if this was a helpful thing or a good thing. Allow a moment free of predetermined assumptions about what's going to have the moment actually occurring with the individual. And as we always said, that could be 10 minutes, that could be 25 minutes, that could be 46 minutes. It's what the moment is saying, not a predetermined set.
I am glad that you brought up about the accusation audit, and it dovetails nicely with what I was talking about with the competence and the skill set and what the work that Kirk taught us to do during our postdoc allowed us a skill set to where we could feel good about our work, whether it was in a 12-minute pocket. And all the work that we did in the studying with single session therapy and solution-focused therapy, and really kind of challenging and motivational interviewing. So motivational interviewing and the focus, acceptance, commitment therapy, solution-focused, it gave us a different skill set so that we could feel good about our visits. And then, so now I kind of feel good about the visits regardless. If it's 10 minutes or 12 minutes, I know that we got something done. And then it allows me so much more space to feel good about seeing a lot of different folks and being able to see them in the moment that they needed care and to be able to support my teammates along the way. So I guess this is a bigger topic. Yeah, this is a bigger topic than just
It always is.
Get your newbies to stop being so obsessed with the 50-minute hour. It turns out, and we said in the one PCBH snippet that I did that it takes 1 year really to get a BHC up and running. But at the end of that snippet, I say, well, actually, in all reality, it's probably closer to 3 years. And I think having this, I think it can take 3 years.
You know what I'm thinking about? This is perfect timing with, because I know a lot of people, as this is going to come out, are going to be about to onboard new interns.
Good call.
I'll end with this. My mind just came up. I think the first question I'm going to ask the new interns coming in is say, how does your mind define good care?
Oof.
And then just allowing that and then having a really good conversation about
frank conversation.
Where does that come from? What is it attached to? What emotions come up with that? Because that is probably one of the biggest barriers of PCBH uptaking.
Good call.
Yeah. Awesome.
Well, I'm not sure exactly what our time was on this, but I think we probably went over. But at this point,
the moment allowed it.
The moment allowed it, and it is what it is.
Thanks for stopping by as always. Leave comments, thoughts, let us know where your mind goes.
And subscribe.
Subscribe for sure. Hit that subscribe button. We always like the subscribers. But thank you for stopping by today.